Po této přednášce mi dovolte, abych uvedl dalšího přednášejícího, profesora Jeana Pierra Pelletieho ze stejného pracoviště, kde dělá i šéfa. So it's my pleasure to welcome Professor Jean-Pierre Pelletier with his talk. Studies using quantitative MRI show that chondroitin sulfate treatment reduces disease progression and total joint replacement in symptomatic knee OA patients.
Thank you very much. I also want to thank the organizer for giving me the opportunity to be here this morning in the very sunny Prague, which was surprising because on the internet they forecasted a lot of rain. So this is great pleasure to be in a sunny day like that. And a beautiful place. This monastery is outstanding, and with very nice and very beautiful people. And I would like to join my voice into the other one, which have underlined the outstanding career of Professor Pavelka. Karel and I and Joanne have known each other for now a long time. We have been on the road for quite a while. And I will say that Karel has been one of the outstanding scientists in the field of osteoarthritis for a number of years, both at the European level, but also at the international level. I believe bringing a lot of highlight to Czechoslovakia, to the field of science, and I would say outstanding science. So it's a real pleasure for Joanne and I to be here this morning and to honor Karel. From my part, if I can get these slides to move, and hopefully no one will disappear from the map. I'm just going to bring you into a little story that is now 35 years old, is how do we manage to get the good treatment of osteoarthritis on the ground? Is it possible that we can do that in a lifetime as we're getting older? And we're quite impatient to see the first D-mode on the market so that the patient could benefit from it. So when we started to do a number of studies, we have used X-rays like everybody was doing at the time, and we got quite frustrated of dealing with bad technology that a lot of people were saying that was still good, which is, in Quebecois, is BS. So we thought that we had to move ahead and bring together some imaging technology that will allow to assess disease progression and will also be able to allow to be used in clinical trials and providing with very precise evaluation of the effect of treatment and whether or not the new treatment we were testing were really able to change the evolution of disease and the prognosis of patient. This is my disclosure slide. So when we deal with OA patient, we deal with patients which have symptoms, mainly pain. And they have loss of function, loss of quality of life, and also most of them are essentially going down the hill slowly but surely over the years. So we wanted a treatment, a comprehensive treatment that can relieve symptoms, improve function and quality of life, will hopefully reduce or stop disease progression, and has good safety profile, remembering that these patients are suffering from a chronic disease and they will need treatment for a large number of years, 20 years, 30 years, maybe even more. So where do we stand as of today, looking into some of the D-mode trial that has been done so far using X-rays, and I will talk more precisely about CICEDO in this talk, but obviously there has been a large number of trials we have realized using X-rays and MRI, but I'm going to pinpoint to the latest one, which provide interesting finding, particularly with regard to disease-modifying properties, and also possibility for dose treatment to change the prognosis of these patients, to improve the prognosis of these patients. When we look into the, more specifically into a number of trials that were for 2 years duration, using chondroitin sulfate, a D-mode which has been previously presented to you by Joanne. There was, in fact, evidence that chondroitin sulfate giving for knee-OA patient over 2 years period could reduce the disease progression. The effect was classified or was qualified as being modest with an effect size of 0.23, but nevertheless, the number of trials were small. 2 years into a demo trial is a very short period of time, particularly in the life of an OA patient. Nevertheless, positive finding. Another positive finding from a meta-analysis is looking at this time into the entire studies that were done with chondroitin sulfate in the OA patient, mixing together 1 and 2 years trials, looking into the effect size, the reduction into the progression of disease, using x-rays. Again, the effect size was 0.26, small but significant, indicating that the drug was able, through x-rays, to provide some reassurance about potential disease-modifying effect. Remembering that x-rays, obviously, as I mentioned at the beginning of my talk, is providing with very limited information. Essentially, for an OA patient, it provides you with how fast is the joint space in the medial compartment is reduced in size over time. So essentially, this is an indirect measure of the loss of cartilage. It does not provide you with additional information about the other structural changes that we do see happening in OA, for instance, at the bone level, at the synovial membrane level, at the meniscus level. So very limited information and somewhat frustrating. This is why there has been, in the last 10, 15 years, progress at bringing new imaging technology, and particularly MRI, into the field of OA. Well, because essentially this technology can provide you not only with beautiful images, but images that provide objective criteria for the assessment of structural changes, is reproducible, sensitive to change, and not harmful to health. When we started in the field, there was a lot of, I will say, evaluation of disease progression, even with these beautiful images that were essentially a scoring of the structural changing happening at the cartilage, synovial membrane, subchondral bone, etc. That was done on a semi-quantitative measure. That means that the musculoskeletal experts reading these films over time were using their eyes to assess the changes. MRI is a very sophisticated technology, and a technology that uses pixels. And sometimes, the pixels are like small cubes. It's like your ID TV, smarter than the eyes. A lot of the changes, particularly very small changes, you just can't appreciate with your eyes. So this is why we have started developing technology using 3D reconstruction with computer that allow to assess not only the structural changes very precisely with hundreds of thousands of point of readings of these pixels, through semi-quantitative technology to start with, that means still having a human intervention with a computer, and eventually fully automated technology that is with no human intervention, letting the computer to analyze the data would provide with very sensitive, reliable data about structural changes over time of bone, cartilage, osteophyte, synovial fluid, bone marrow lesions, and meniscus. This has helped in establishing much better clinical trial. This has helped in understanding much better the pathophysiology and structural changes of knee OA and hip OA over time. And this is a beautiful pictures of what a 3D reconstruction of a human knee look like when we assess cartilage thickness. This is a real knee. This is the cartilage thickness. The thickness map is, the blue is the sky. It's very thick cartilage. 5 millimeters is normal. Down to 0 is health. No more cartilage. And this is essentially what you do see in this patient, where the cartilage in the medial compartment on both condyle plateau was almost completely lost. This patient is suffering from severe osteoarthritis. As you could see, you could estimate the change in thickness, not only the thickness per se, but also the location of those changes. And you can quantify those by computers. We could also assess bone marrow lesions, which are grayish discoloration of the bone marrow just beneath the cartilage. And this particular lesion is believed to be very important in inducing cartilage loss. And the reason is that most of these lesions are essentially representing an inflammation of the subchondral bone that are eating up and digesting the cartilage which is adjacent to those lesions. Therefore, the bone marrow lesions, as you will see, are quite important. We have managed to be able to build software that can allow to measure those bone marrow lesions location and size through fully automated technology. That means that we could, without the intervention of a human eyes, we could assess sensitively and reliably thousands of films, which are quite important because when you assess population of patients or when you run trials, you have several hundreds or several thousand films that you can only assess accurately if you have fully automated technology, allowing to avoid mistakes that can be made by the human eyes and multiple human intervention. As when you have thousands of film to read, you cannot use only one readers, but you have to use multiple readers, which make the data to be much less reliable and strong. Additional information that we got from the MRI is the lesions at the meniscal level, whether it's tear or extrusion. And those are important because, as we're going to see, they are not only leading to disease symptoms, but also the extrusion and tear are responsible for inducing an increased loss of cartilage over time. Now, what about these beautiful technology and pictures I've shown you? How do you translate those into real life? Well, we had done, in our group, we did the first phase 3 trials using MRI in NeoA patient. And we did a number of other studies, and this is one of those, this time looking into the D-mode effect of chondroitin sulfate in NeoA patient. It was a 6-month double-blind studies that lasted total for 1 year because there was an open phase of 6 months following the first 6 months. And we look into these patients with regard to the effect of the drug on disease progression, cartilage, subchondral bone, as you will see, and more importantly, the impact of such treatment on the outcome of the disease. This is in brief the design of the studies. As I say, 6 months of treatment, placebo vis-a-vis chondroitin sulfate, 800 milligram a day. In the open phase, both arms of the studies did receive chondroitin sulfate, 800 milligram. They had MRI baseline, 6 and 12 months. In very brief, the data showed that there was, both at 6 and 12 months, a very positive effect of chondroitin sulfate in the loss of cartilage in the lateral compartment and the medial plateau. There was a significant reduction, and it was quite significant, not only from a statistical point of view, but as you will see, there was a reduction of about 75% of the cartilage loss in the chondroitin sulfate treated patient vis-a-vis placebo after 6 and after 12 months. And these are the numbers here, as you could see. The cartilage volume lost in the laterofemoral compartment, placebo, chondroitin sulfate, almost no loss into the chondroitin sulfate arm compared to the placebo arm, 75% reduction. The reason why most of the effect was seen in the lateral compartment is of no surprise, because remembering that these patients do have moderately severe disease, they already have experienced severe loss of cartilage in the medial compartment, so there's not much more to lose. So in the late phase of the disease, most of the loss of cartilage is happening into the lateral compartment, and this is where the drug could be actively promoting cartilage sparing effect. This effect, positive effect on cartilage loss by chondroitin sulfate, was related, as you can see here, by a reduction in the progression of the bone marrow lesions. The bone marrow lesion in the lateral compartment in the placebo arm, even if those had received chondroitin sulfate in the last 6 months, was progressing over time, as I would say normally, because if you don't treat patient, the BML usually will progress in severity, that means in size, and increase in numbers over time. But chondroitin sulfate was quite effective at reducing the progression of bone marrow lesion, and as you've seen, bone marrow lesion destroy cartilage. Therefore, if you stop the progression of the BML, the bone marrow lesion. You stop the progression of the loss of cartilage. How does that translate into real life? Because a lot of people will say, well, this is nice pictures, beautiful computer data, beautiful statistical analysis. What does it mean in real life for the patient? Well, what we did was to follow this patient over time, 3 years after the end of the study, so therefore 4 years total. And we look into what happened to this patient from a prognosis point of view, looking into the incidence of total joint replacement. And to make a long story short, as time flies, we were able, out of the 70 patients that were included into that small study, to retrace 51 patients. 7 patients had total knee replacement, 6 into the signal knee, the most symptomatic knee, and 1 in the contralateral knee. So pretty good. 7 events out of 51 patients over a period of 4 years. It's small, but it is the average that you will see in any knee OA patient cohort, about 2% a year. What are the predictive factors for total knee replacement in this particular cohort of patients? Well, in line with previous phase 3 studies we did, patients that were more symptomatic had a higher WOMAC score, had a greater incidence of prosthesis that was statistically significant. And this could be understood because obviously if you're in severe pain, the likelihood you will need a total joint replacement quickly is pretty high. And interestingly, CRP, biomarkers of inflammation, was higher in the patient that had total knee replacement, and this is likely reflecting synovial inflammation, which lead to more rapidly progressive disease. And this is something we had previously reported in the lycophyllin study. Baseline characteristic and predictor of knee replacement, looking this time at the imaging portion of the studies. Well, bone marrow lesion in the middle compartment was associated with an increased risk of total joint replacement. Cartilage volume at baseline was not. When we look into more details about the change at 1 year and risk of total knee replacement, essentially, as you could see here, patients that had more symptoms, particularly stiffness, were having a higher risk of total joint replacement, and patients that over time lose more cartilage in the medial compartment. And this is now well recognized by everybody in the field, that the loss of cartilage in the medial compartment is one of the best markers for prognosis or for total joint replacement in a knee OA patient. That was therefore clear. And this was also a finding that came out across in the lycophyllin study. If you lose a lot of cartilage, then the likelihood you will have prosthesis is pretty high. And from a multivariate analysis, when we took into account all of the risk factors, again, the symptoms came across as very strong predictor, and the bone marrow lesion also came across as very strong predictor. So therefore, the MRI is providing with some interesting information that can allow to predict total joint replacement, but moreover, it provides with an accurate estimate of disease progression, structural changes over time, and also provide you with interesting information about the mode of action of a drug. And these are the data from the Kaplan-Meier survivor curve over time, placebo 33%, vis-a-vis 13%, therefore a reduction of 60% in the incidence of total joint replacement, which a number which is well in line with the 75% reduction in the loss of cartilage. So the conclusion from that study, these data demonstrate that in knee OA clinical trial, it's possible to predict a hard outcome such as total knee replacement using clinical and quantitative MRI data. These results are highly encouraging and support the use of qMRI as a surrogate to joint tissue damage upon which a disease-modifying drugs such as chondroitin sulfate may act. Therefore, not only useful to assess structural changes, but also to assess outcome. The study, obviously, that was done with chondroitin sulfate is a small pilot one, 70 patients. There is a conclusive study which is now underway with 200 patients, and the data should become hopefully available by the end of this year. In the meantime, can we be sure that the effect we have seen in that proof of concept study are real? And for that, and as it was mentioned by Joanne, we decided to look into the OAI cohort, which is the NIH projects. There's over 4,000 patients that has been followed for over 6 years. And there's a number of those patients that do have truly OA, and the other one are just patients at the risk of having OA. So we decided to look into the OA cohort in trying to estimate whether or not the observation of the disease-modifying effect of chondroitin sulfate could be also proven through that particular observational study. And for that purpose, what we did was quite simple. We tried to mimic the data set of a clinical trials. So we took patients out of the first 4 years of observation that had complete follow-up for 24 consecutive months. All of the clinical information, all information about the administration of drugs, and also all of the images, MRI and X-rays. And at the end of the day, the perfect cohort was 600 patients out of the 1,390 that we started with that was able to fulfill the criteria. And then we stratified those based on whether or not they were receiving the usual treatment for OA, which are analgesic and NSAID, yes or no. And then we further stratified each of these groups into whether or not patients were receiving glucosamine chondroitin sulfate. Remembering that you are in the United States and most of the available drugs that contain chondroitin sulfate and glucosamine are available combined together. In fact, there was less than 1% of the patients that were taking only glucosamine or chondroitin sulfate. All of the other ones were taking a combination. So this is why, from a practical point of view, we decided to use a combination. So the knee structural changes in these patients were assessed, as I mentioned, by X-rays, looking into joint space width, Kellgren and Lawrence score, and also by MRI, looking into cartilage volume, bone marrow lesion, etc. All of those that we have described to you. And we did use the fully automated software that we have due to the extremely large number of MRI images we had to analyze. To make a long story short, the data are superimposable to very much the one we saw into the proof of concept study. First is that the patient without analgesic NSAID were having milder disease, both on symptoms, both on the X-rays, Kellgren and Lawrence score, and also on MRI, having better cartilage volume, better preserved volume. But for those who were followed for 2 years, patients that were receiving glucosamine and chondroitin sulfate were experiencing significant protection on condyles and plateaus, and more so for those who had a wider joint space width. That's mean even among the milder, more milder. That's mean very early stage of the disease. For those who took the analgesic and said these patients usually have more symptoms, smaller joint space width, less cartilage volume to start with, but nevertheless they did experience a protective effect on both plateaus. So that are quite superimposable again to what we have seen. Maybe a little better, because this time not only the lateral compartment was protected, but also the medial compartment. That is in line with what I did say before, is that in this particular cohort, the patient that did not take analgesic and said had very mild disease still had cartilage left in the medial compartment. Therefore, the chondroitin sulfate glucosamine combination could exert its protective effect. So general conclusion from the data that I presented to you this morning is that from both clinical and observational studies, There's support for the structural modifying effect of chondroitin and the combination of glucosamine and chondroitin sulfate in knee-OA patients that are also consistent with the hypothesis that the individual with milder structural changes will benefit more from structure-modifying agents, such as glucosamine and chondroitin sulfate, than those that have more severe disease. Treatment with chondroitin sulfate can reduce the need for total knee replacement. And for those of you who will be attending the EULAR meeting, would like to invite you. We are having a number of presentations that are an extension of this very first paper we did that will provide you with even more exciting data about this particular OAI cohort and the D-mode effect of glucosamine and chondroitin sulfate. Thank you very much.
Professor Pelletier, thank you for your outstanding talk and compelling data on the efficacy of chondroitin sulfate. Since the time is flying, as you said, we have just one short question time. And if it's not the case, just please stay on the stage, and I'm just with the present